Hello everyone, welcome back. This is Dr. Pruitt and I'm glad you're here for this week's EKG. Our presentation is an 86-year-old male who called 911 because he's had 2 weeks of worsening trouble breathing when he's exerting himself, going up the stairs, walking to and from the car. Today it got especially bad and he thought he was going to pass out. It got a little better when he sat down, but he really thought something was wrong, so he called 911. We get there, do a very good evaluation. We see his vital signs. He's got a heart rate of 72. He's a little hypertensive at 167/87. Oxygen, he's 92% on room air, but he's a little tachypnic at 24. And his end tidal is 36. And so appropriately with near syncope or any shortness of breath complaint, we go ahead and get our 12 lead. This is what we see. I'll give you a second here to take a look and come up with your diagnosis, and then we'll go through it together. Okay, so just like always, we're going to do this the same way every time. We start with rate. The computer is telling me that it's 79, so I'm just going to see if I agree with that. I look for a QRS complex that lines up on a thick red line, and then we count down 300, 150, 100, 75. So somewhere between 75 and 100, 79. I agree with the computer. I think it's spot on there, so we'll call this rate 79. Next, we move to rhythm. So we ask two questions here. Is there a P wave before every QRS? That would tell us if the sinoatrial node is working. You can look in two leads. You can look in V1 or you can look in 2. I usually look in 2. I see a P wave here, P wave here, P wave here. We can follow all the way across the 12 lead. It looks like each QRS has a P wave before it. I would call this a sinus rhythm. Next question, is it regular or irregular? I don't have any calipers here, but to the naked eye, this looks like a fairly regular rhythm to me. I don't see any big red flags, so we'll call this a regular sinus rhythm. Next, we move on to axis. And if you remember, this is where we focus on leads 1 and leads AVF, and we get to use our thumbs. So the majority of the QRS vector in lead 1, that's our left thumb, is up. The majority of the QRS vector in AVF is down. We have our left thumb up. That's left axis deviation. Pretty clearly there. And then we'll get to why that's important in a second, because as we move on to intervals, this is where it gets interesting. Our two most important ones that we tend to look at the most are our QTC and our QRS. Our QRS here is 130. That means that this distance between the Q wave and the S wave is a little bit wide. What defines a wide QRS is greater than 120 milliseconds, and we have 130 here, so we have a wide QRS. Then we look at our QTC. QTC is corrected for rates 399. That's fine. 450 for most adults is long. We're well below 450, so I'm not worried about that, but we do have a wide QRS. Anytime I have a wide QRS in the setting of a sinus rhythm, I think about a bundle branch block. So I look at lead V1 here, mostly up in V1. So I see we have a right bundle branch block. I'll talk about that a little bit more in a second. Then we move on to our ST segments, and we're looking for any T wave inversions or ST elevations or depressions. And you can use your baseline here. I usually read 2-3 AVF first and my inferior leads. Then I move to my high lateral leads. Again, the baseline looks pretty good to me. I don't see any T wave or inversions or anything concerning for ischemia there. Same thing in the septal. The septal area is maybe just a subtle, like one box in V2, but you have to have, to meet STEMI criteria, you need 2 small boxes with of elevation with reciprocal changes in your other leads. I don't see any of that here, so I won't really call that. I notice it, but I don't think it's enough to do anything about right now. And all the others look okay. So in terms of ST segments, I would call those normal. As we look a little bit closer at this 12 lead, if you remember, when we're talking about right bundle branch blocks, the things you need that should tip you off, you have a wide QRS. We caught that because we read this together. And then we have P waves present, which we also caught. So then you always look at V1 and you ask yourself, is there a bundle branch block? The thing that gives this away as a right bundle branch block is the majority of your QRS vector is up. Just like your turn signal, when you turn that up, you turn to the right. in your car, that's a right bundle branch block. Sometimes people say it looks like an M shape or rabbit ears. Okay, so we do have a right bundle branch block here, but the thing that's very subtle and very important is that we also have a left anterior fascicular block. It's a little atypical in a right bundle branch block to have left axis deviation. Usually you'll have right. And what else we see here is that there's a big R wave in 1 and AVL. Those are kind of tall compared to normal. And then we have S waves here that tell us that we have a left anterior fascicular block. And so when you have a right bundle branch block, when we think about these electrical conduction pathways, right bundle, left bundle has 2, right? You have anterior and posterior. 2 of the 3 major conduction pathways in this heart are struggling. This is a really big deal, and it's very subtle. But this can be due to ischemic heart disease, structural heart disease, most common, and we have a patient who's having exertional near syncope. And so he is at very high risk of moving on to complete heart block, actually 17% risk in the next year for maybe needing a pacemaker for this. So this is a warning sign, something you should look at, especially if you're thinking about getting a refusal on these patients. It doesn't scream out to you, but it does suggest that this is not a healthy heart. So as we put this together, we have a sinus rhythm with a rate of 79 in the setting of a right bundle branch block with left axis deviation. So this gives us a bifascicular block. And that is all I have for you today. Thank you for your attention, and we'll see you next week.